Hello, everyone, and welcome back to another session on clinical case discussion, where we discuss very important clinically relevant topics, cases that you see day to day in your routine, OPDs, inpatient, and emergencies. Okay, so for today, we have with us a 67-year-old male whose known case of hypertension and diabetes has come to you with 2 episodes of transient right upper limb weakness, which lasted for about 15 minutes in the past 1 week. Okay. There was a mild slurring of speech during these episodes. However, both of these episodes resolved spontaneously without any residual deficit. So when you take a further detailed history, you find that there is no complaint of loss of consciousness or impaired awareness in any of these episodes. There was no complaint of any tonic-clonic movement of any limb, any urine or fecal incontinence in any of these episodes. There was no complaint of any febrile illness, fall, trauma, or head injury. So, what do you think at this point of time? An elderly male who has some vascular risk factors coming to you with 2 episodes of transient right upper and lower limb weakness, which recovered spontaneously. So, number one on your list is going to be stroke, which is a focal neurological deficit, but it is something which recovered by itself and your patient is absolutely normal. So, what is the counterpart of that? That is TIA, which is a transient ischemic attack, right? But is that the only thing that you will consider? What are the other differentials that you will make at this point of time? They can definitely be a seizure, although you did not get any history of tonic-clonic movement or you did not get any history of urinary or fecal incontinence, tongue bite, frothing, but still you need to rule out seizure in such cases. Then yes, you may have transient episodes of hypoglycemia, which is also a mimicker for stroke, can produce exactly similar episodes, right? Then there can be drug effect or toxin effect, but these generally would not result in a spontaneously recovering deficits, right? So whenever you have a patient with transient neurological deficits which have recovered spontaneously, the important differentials that you need to make and consider is number one, transient ischemic attacks, number two, seizures, number three, hypoglycemia, plus minus any drugs or toxins, right? So the discussion today we are going to focus on is going to be TIA, right? So now we are going to discuss how do we approach a patient with transient ischemic attack. So before we discuss the approach, we should know what exactly is this entity, right? So transient ischemic attack is an acute onset of focal neurological symptoms followed by complete resolution, right? So this is where TIA differs from stroke. Both are acute onset focal neurological disorders, but in TIA, you have complete resolution without any interventions. Okay. Now, recently the definition was redefined. Now we use a tissue-based approach. Now, what is the tissue-based approach? It means that there should be symptom resolution, which you see clinically, plus you should have absence of infarction on brain imaging as well. Okay, so you may have a clinical scenario where your patient weakness has recovered spontaneously, but when you do the MRI brain, you find a small lacunar infarct. So does this patient qualifies as TIA? No. Only and only if there is a complete recovery and the imaging shows no evidence of brain infarction, that is when you label your patient as TIA. Correct? So this is what is called as tissue-based approach. What we were following earlier was a time-based approach where we used only symptom resolution occurring within 24 hours of the onset. So remember this very important change in the definition. There should be complete resolution of symptoms within 24 hours. Plus, there should be no evidence of brain stroke on imaging. Okay, so if you have either of the one component satisfied and the other not, your patient does not have TIA. So you can have a scenario where the patient's symptoms resolved, but the imaging shows lacunar infarct. So this is stroke. However, you can have the other end of the spectrum, that the symptoms are persisting beyond 24 hours, the imaging still not showing stroke. So this is not TIA. You need to evaluate for other causes. Okay. So TIA, once again, is two important things: complete resolution of symptoms within 24 hours and no evidence of stroke on imaging. Okay. Now, why are we so focused on this entity, right? So when symptoms have resolved within 24 hours, we don't have any evidence of imaging. So why are we so bothered about this entity? We are because if your patient has had TIA, there is an increased risk of stroke in your patient, okay? So the increased risk of stroke after a transient ischemic attack is about 10 to 15% within the first 3 months, with most of the events occurring within the just first 2 days itself. Okay, so this is the reason why we are so focused on this entity, because if you manage this entity adequately, you are negating the risk of stroke in your patient. Okay, so with that basic introduction, we move ahead to how do we clinically evaluate such patients, right? So you ask in your patient, when were they last seen well? What was the focal neurological deficit? How much time did it take to recover with it? You need to rule out the mimics of TIA. Look for the risk factors of TIA in your patient. Okay. So why is all of these parameters important? Because each of these is going to decide an important critical step in the management. Okay. Now, what can be the focal neurological deficits that your patient can present with in patients with TIA? So, any transient episode of neurological dysfunction. Now, where all can you have this dysfunction? It can be there in the brain, spinal cord, or retina. Remember, without acute infarction or tissue injury. Okay, so you can have a dysfunction not only of the brain but also of the spinal cord or retina. So any of the three sides, if you have focal neurological deficit which was acute, transient, recovered spontaneously, qualifies into TIA, with a caveat that there should be no evidence of infarction on imaging. Okay, now, what all clinical features can you notice in these FNDs? You usually notice hemiparesis, like our patient had. You can also have visual disturbances, as simple as blurring or some visual field defects that came and went by. You can have facial deviation, slurring of speech. So, all of these would indicate TIAs of the anterior circulation. However, you can also have dizziness, vomiting, ataxias, which will indicate TIs of the posterior circulation. Okay. Rarely, you can also have transient aphasias, hemisensory loss, or paresthesia. So it is almost anything and everything in the neurological axis you can have confining to brain, spinal cord, or retina. Remember, they have to be acute, they have to be transient, recovering within 24 hours without any evidence on brain imaging. Okay. So once we have seen the focal neurological deficit, so once we have known that, okay, yes, this is what happened in our patient, the next important step is to rule out the mimickers. Okay. Now, how do we do that? Now, TIA generally we see in the older patients, the ones which have vascular risk factors, like our patient did. However, if a young patient, especially the ones which do not have vascular risk factors, the chances are that they have TIA mimics more than the TIA. Okay. Then if you have vascular risk factor like diabetes, hypertension, coronary artery disease, smoking, obesity, atrial fibrillation, previous history of strokes, hence and so forth. So a long list of vascular risk factors, if present, yes, predisposes to stroke, predisposes to TIA. However, if your patient has had history of epilepsy, migraines, brain tumor, likely possibility that this is a TIA mimicker. Then if the symptom was abrupt in onset, it was all out of a sudden, it was maximal at the onset with the duration generally lasting between 60 minutes with a preserved mentation, preserved awareness, and a neurological symptom which is confining to a particular vascular territory, say dysarthria, facial droop, hemiparesis, hemibody numbness. All of these features, they indicate that this is actually a TIA. Whereas if you have symptoms which have marched from one side to the other, your patient has altered sensorium, patient has headache, okay, so all of these will point towards TIA mimickers. And what kind of mimickers? They can be seizure, they can be migraine, they can be simple hypoglycemia. Okay. So although not very hard and fast, simple clues that you can get how to differentiate between TIA from TIA mimics. If the patient is elderly with a vascular risk factors coming to you with symptoms which were abrupt, confined to a vascular territory, duration lasting between 60 minutes, and with preserved mentation, think more of TIAs. However, young patients, especially on a background of epilepsy, migraine, with symptoms which are waxing and waning and are not confined to a particular vascular territory, think about TIA mimics. Okay. Then, what are the risk factors that you need to look for? So, these risk factors are more or less the same that we discussed in our session on ischemic stroke. Okay, so first and foremost, being the age, which is the non modifiable risk factors. Then we have a long list of modifiable risk factor: hypertension, diabetes, smoking, dyslipidemia, sedentary lifestyle, obesity predisposing to OSA, any past history of stroke, be it ischemic or hemorrhagic, any family history of stroke, okay? Any cardiac involvement, whether in the form of coronary artery disease, myocardial infarction, rheumatic heart disease, or AF, or any malignancy. Now, why malignancy? Because malignancy is a prothrombotic state, right? So remember the risk factors: age, hypertension, diabetes, smoking, dyslipidemia, obesity, any past or family history of stroke, any cardiac history, or malignancy. In the examination, do a very thorough examination of the pulse rate, rule out atrial fibrillation. We will see why that is important. Then check for their blood pressures, sugars, and yes, do a detailed neurological examination to make sure that there is no residual deficit which is left. So, how do you check for the neurological deficit? You have the NIHS, which is the National Institute of Health Stroke Scale Score. Okay, so remember these words, very, very important, very oftenly asked in your MCQs and OSCEs. So, it is the National Institute of Health Stroke Scale Score. Okay, so what is this? This is basically an 11 items score where the maximum score is 42. Okay, so as medicine residents, ideally you should all be certified in doing the NIHS. Even if you are not, that is okay. You can go through these lists, which are very easily available on the online internet. What you need to remember is that you need to score the first response and not the best response. You don't have to assist, you don't have to give clues so as to improve the response. You just have to check the first response, right? But there are fallacies of NIHS, and what is that? It is more so directed to pick up the anterior circulation strokes and more so the left-sided strokes, right? So the posterior circulation strokes are not very well depicted into your NIHS, okay? But nevertheless, this is a very important tool that we use in the emergency management of strokes. You should know the full form, the National Institute of Health Stroke Scale Score. 11 item score where the maximum being 42. Remember to score the first and not the best. Okay. Now coming to a very important score which is specifically tailor-made for patients with TIA, which is the ABCD2 score. Okay. Now this is a score which you should know by heart. Okay. And the only way that you can know by heart is when you keep practicing it over and over again. Okay. Because practice is what makes us perfect. Right. So what is this ABCD2 score? It is a very, very simple score. A stands for age, and what is that age? Okay, so you don't have to just know the components that okay, A stands for age. No, you also need to know what age is it depicting. Okay, so it is depicting an age of more than equal to 60 years, right? B stands for blood pressure, and how much blood pressure? Systolic of more than 140 and diastolic of more than 90. Okay, so any blood pressure of more than 140 by 90 gets a score of 1. Okay, C stands for clinical symptoms, right? So if you have unilateral weakness, which is one-sided hemiparesis, you score it 2. However, if you have speech disturbances without weakness, you score it only 1. Okay, so our patient had weakness along with slurring of speech. So what will be the score? It will be 2. Okay, the duration, if it is lasting more than 60 minutes, will be 2. However, if it is between 10 to 59 minutes, it will be 1. Now, D2, you have 2 Ds, you have duration and you have diabetes. Again, you score them 1. Okay, so remember ABCD2 score. Remember the individual components where you have age more than equal to 60 years, B, blood pressure of more than 140 by 90, C is the clinical features, D, you have 2 Ds, duration and diabetes. Okay, so that is one that you need to remember. You also need to remember which entities have been scored 2 and not 1, right? So what are the 2 entities? The unilateral weakness and a duration of more than 60 minutes, you score them as 2. Okay, so remember, everything else is a score of 1 except unilateral weakness and duration of more than 60 minutes, which gets a score of 2. Okay, now going back to our clinical case. So our patient was 67-year-old male. So score would be in age will be 1. The blood pressure was okay. So here the score would be 0. He had unilateral weakness. So the score will be 2. The duration was lasting for 15 minutes. So the score will be 1. And he was a diabetic patient, right? So we have a score in age. We have the score in the unilateral weakness. Duration is 1, diabetes is 1. So what is the total score in our patient? It is 2 plus 1, 3, 4 and 5. So the score in our patient is 5, right? So it's a very easy to calculate score, easy parameters to remember, but the only way that you will be actually able to do it if you keep practicing it day in and day out. And trust me, you're going to have way too many TIA patients in your OPDs, inpatients and emergencies that you can practice this almost every day. Okay. So the total score that we calculate, the maximum is going to be 7. Okay. Now, what is this score actually telling us? Why are we so fond of it? Why am I emphasizing that you need to remember it, even the basic parameters, which score is having 1, what is 2? It is not just for your MCQs and OSCEs. It is important because it has a lot of clinical implications. And what is that clinical implication is, it calculates the 3-month rate of stroke, right? So remember, what was the whole idea of learning about TIA in so much detail? It's we need to prevent further strokes, right? So we need to predict that which patient has a higher risk of developing stroke, whereas the ones which have a lower risk. And the score that helps us to do that is the ABCD2 score, okay? So the maximum scoring you can have is 7. And what it predicts is a 3-month rate of stroke, right? And any value of more than equal to 4 in this is classified as a high risk TIA, right? So ABCD2 score is important not only for your MCQs and OSCEs. Yes, you will have lots of them on this score, but it is important for your clinics as well. Again, emphasizing, remember the parameters, not just the parameters, but what values are there, which entities are getting a score of 2 and not 1. What is the total score? 7. What is a high risk TIA? More than equal to 4. And what is it trying to tell us? the 3-month rate of stroke. Okay, so each and every thing that we have discussed here is very, very important. Okay. However, like any other score, this score also has its pitfalls and shortcomings. Now, what are the shortcomings that are there in this score? Number one, that it does not include symptoms of posterior circulation, right? So you saw in symptoms, we just had unilateral weakness, which is hemiparesis, and speech disturbances, right? We did not have features of posterior circulation stroke such as dysmetria, ataxia, or homonymous hemianopias. So that is the biggest pitfall. It does not include features of posterior circulation stroke. Number two, it does not account for the TIA mechanism and for the presence of any stenosis that we find in imaging, right? So number one, it doesn't include posterior circulation stroke features. Number two, it does not include the imaging features, right? So to overcome these pitfalls, now we have the newer scores. As residents, it's okay if you do not remember these ones in detail, but ABCD2, at least that one you should be remembering completely, okay? Now what we have, the new one is D3, okay? So we have added another D into it. And what is that D? That is basically dual TIA. Now what is this dual TIA? Where you have more than 2 episodes of TIA symptoms in the past 7 days. Okay, so if you go back to our patient has had 2 such episodes in the last 1 week. So that is what we call as dual TIA. So that itself become an important risk factor, which further increases the risk of stroke. Okay, so that is something which has been added into an extra D, right? Then we have a further modification where we have ABCD3 with an I. Now, what is this I? This is the imaging findings. Now, these imaging findings are predominantly related to the carotid stenosis. Okay. So remember the ABCD2 score in detail, all the points that I told you. Remember that there are newer modifications to it, D3 and D3I. What is the extra D? The dual TIA. And what is the extra I? It is the imaging findings. Okay. So once you have applied those scores, we move forward to how do you investigate your patient. So you do a routine blood checkup. Now, what all do you send in the blood? You check for their complete blood counts, the inflammatory markers like ESR, CRP, do the complete metabolic profile, including the livers, the kidney function test, thyroid, HbA1c, lipid profile. Also check for their B12 and serum homocysteine levels because these are the independent risk factors for stroke. Okay, so these are the routines one that you send out in all patients of TIA. However, if you have a young patient, right, so you need to think of factors which are beyond the conventional metabolic risk factors. So you do the ANA, ANCA, ACE, and the thrombophilia screen. So basically looking for the vasculitis and the thrombophilic markers. Okay. You do need to do a thorough cardiac evaluation, not just the ECG and echo. Now you should also be doing the extended loop recording, which is simply put a Holter, which was for 24 hours. Now you do it for 3 days, 7 days. You can do it even for prolonged durations, right? So that should also be included into your investigations list. Last and foremost, don't forget to do the neuroimaging, right? Just because your patient's symptoms have resolved, that doesn't mean that you don't do a neuroimaging. It is very, very important to do the neuroimaging, not just including the imaging of the brain, but you also need to screen for the vessels, okay? Now, coming on to the neuroimaging, you will obviously be doing the imaging of the brain. You can do an NCCT head. Preferred would obviously be an MRI brain, but you also need to screen for the vessels, like I said. Now, that you can do by doing a CT angio. You can do an MR angio. If your patient does not have an access to either of the two, you can at least do a carotid Doppler, but you need to screen for the vessels. Why? Because remember that the newer modification of D3I, we have carotid stenosis, right? Because that has a management of itself to reduce the risk of the further strokes, okay? Now, what do you see in NCCT head, right? So if your patient has TIA, the NCCT head should be normal, right? But however, if your patient has early stroke, okay, How do you pick it up? Now, this is something that you should be able to pick up as residents. You don't have to wait for your radiology colleague to come and tell you that, okay, yes, this is an early stroke, this is an acute stroke. As residents, when you are there with the patient, you are there when the CT is happening, you yourself should be confident enough to pick up the acute stroke. Okay, so simple signs what you see are the hyperdense MCA, right? So whenever there is a clot which is forming, the clot is going to be hyperdense. So anything which is hyperdense appears bright on the non-contrast CT. Okay, so non-contrast CT, the normal parenchyma is something like this, grayish, right? But anything which becomes more bright, okay, that is what we call hyperdense. And this in the blood vessel where we see the MCA, this becomes the hyperdense MCA sign. Okay. The next what you see is the obscuration of lentiform nucleus. Okay, so what is the lentiform nucleus? So here you have an important structure which is the internal capsule. Medial to it, here you have an important structure which is called as caudate. Here you have an important structure which is called as thalamus. And here you have this structure which is called as the lentiform nucleus. So this lentiform nucleus basically has two parts, globus pallidus on the inner and putamen on the outside. So the two of them together are called as lentiform nucleus. Okay, so when this lentiform nucleus, so here you can see a gray-white differentiation between the two, but once it is lost, it is obscured. That is also an early sign of stroke. Okay, then you have the insular ribbon sign. So what is the insular ribbon? So the structure out here is called as the insular ribbon. So once it gets obscured, this is called as the insular ribbon sign. Then you have a loss of gray-white differentiation which occurs. Okay, so simple signs on the non-contrast CT that you should be able to pick up, which are the markers of early stroke. So what are these? Hyperdense MCA. Then you have obscuration of the lentiform nucleus, insular ribbon sign, and loss of gray-white differentiation. Okay. In the MRI, how do you pick up stroke? So in the MRI, the sequences that you need to see are the DWI and the ADC. Okay, so these are the sequences that you look for patients who are suspected of acute stroke. So in the DWI, you see this bright area here and the corresponding area appears dark here. Okay, so this is the characteristic feature of acute stroke. It appears bright on DWI and the corresponding area is dark. Okay, so this is how you look for acute stroke on MRI. Then what are the subtypes of TIA? So similar to you, what subtypes you have of acute stroke, you have subtypes of TIA. So you have a large artery erythrothrombosis or atherosclerosis. So you can see here, so here you have the ICA, something that you cannot see here. So the ICA is considered to be large artery. So it's completely occluded here. This is the large artery erythrothrombosis. Then you can have these small vessels also getting involved. That is where you have the lacunar TIAs. Okay. Then it can be originating from the focus in the heart, where you call it as cardioembolic. Some cases you may not be able to find any etiology, so you call as cryptogenic. Then you have an entity of the uncommon types, where you have entities like vascular dissections or vasculitis, right? So the commoner ones are generally a large artery atherosclerosis, small vessel disease, cardioembolic. If you're not able to find any, then it is either cryptogenic or it can be the uncommon causes. Okay. So now coming on to the treatment. So you have done so much of detailed evaluation, investigated your patient. Coming on to, do you offer any treatment to your patient with TIA? Yes or no? The answer is yes. Now the question that your patient will ask, the doctor, I have completely recovered from the deficit. Why do I need treatment? The answer remains the same, that your TIA is actually a marker, harbinger of an impending stroke that might happen in the future. Okay, and this is the reason that you need to start treatment in your patients. Okay, now what treatment are you going to start? So you're going to start the antiplatelets. Now, which antiplatelet, what dose, for what duration? That is answered by your ABCD2 score. So I said an ABCD2 score of more than equal to 4 was a high risk TIA. So these patients are high risk. So what are you going to give them? Dual antiplatelets. For how long? For 21 days. After that, you switch to single antiplatelets, right? Now, in this dual antiplatelets, how do you give them? You give them a loading dose. Now, the loading dose followed by aspirin of 75 milligrams and clopidogrel of 75 milligrams. So this is the recommended one, dual antiplatelets for 21 days. Which patients get it? The ones which have an ABCD2 score of more than equal to 4. Okay. Now remember, stroke, as I had discussed in the previous sessions also, you will find a lot of trials. Every day there are trials coming to stroke, right? Now, as medicine residents, we do not expect you to be aware of all of them, knowing all of them by heart, but few of them, which are especially the landmark trials in stroke, and especially the ones given in your Bible, Harrison, are something that you should be knowing, right? So important landmark trials which gave us this information of using dual antiplatelets in TIA were Chance and the Point trial. So just remember the names, that much itself is sufficient, okay? Then a few trials of clopidogrel alone. I'm just mentioning the names here because all of that is given in your Harrison. Even if you don't have to remember the full name of the trial, it's not expected out of you. Just remember the short forms, Capri, Madge, and Charisma. Just remember these words and just remember the fact that they had used only clopidogrel alone, right? But the recommendation that we are going to follow for treatment is dual antiplatelet for 21 days. Okay. Moving forward, apart from antiplatelets, what all things that you need to look for? Now, you need to focus on managing all the risk factors that you had found in your patient. Okay. So, what were the risk factors? The number one was blood pressure. Okay. Now, what are you going to target? You are going to target to somewhere between 130 and 80 millimeters of mercury, right? And for blood pressure, you need to remember a very important landmark trial, which was SPRINT. Okay. So in SPRINT, they had studied different values, 120, 140. You need not go into the detail of them. Just remember the SPRINT trial name and remember that you need to be managing the blood pressure in patients with TIA. Okay. You need to obviously have a good sugar control for these patients, control their lipids, usually making a target of LDL of about 70. We generally target an LDL of 100 in the general population. However, in patients with stroke, with TIAs, we make it further down to about 70. Okay. And yes, they need to have cessation of the smoking. Okay. So remember, antiplatelets, very important, but that is not the only thing that you're going to focus on. You have to focus on all the risk factors that we had enlisted: diabetes, hypertension, controlling their lipids, cessation of the smoking, finding out, screening for the cardiac abnormalities. And if you find any, then you need to start the therapy for it. Okay. So just summing up the treatment once again. So one definitely is your antiplatelets, where you have to first give a loading dose and then switch to 75-75 of aspirin and clopidogrel for a minimum duration of 21 days. And then you do a transition to the single therapy. Now, the newer agent that we have now is ticagrelor. That is also being used at some centers. Now, remember the trial that promoted ticagrelor was the Thales trial. Okay, just remember Thales trial. Chance and Point we had discussed were for aspirin and clopidogrel. Thales is for ticagrelor. Okay. Then not only focusing on the antiplatelets, the antihypertensive, the lipids, the sugars, the nutrition, smoking cessation, physical activity, all of that has to be included into your management. Okay. And also very important, in the cardiac screen, we had specifically focused on AF, right? So if you do find AF, you need to initiate anticoagulation for your patients, right? So if your patients have AF, you need to start them on anticoagulation, right? So, quickly summarizing our whole clinical case discussion, whenever you have a patient who has a suspicion of a possible TIA, they need to get a neurology consult. However, if you don't have the neurology super specialty with you at medicine residency level, you should be able to handle this case yourself. You need to get the imaging done. Remember the imaging not just of the brain parenchyma, the NCCT head or MRI brain, you need to screen for the vessels also. You need to find out whether your patient has any high risk features. You need to look at their ABCD2 score. You need to look at their imaging, any stenosis that they have. If they do have any high risk factors, you need to admit these patients. If not, you can have them on your follow up. But remember, you need to start treatment because TIA is predisposing your patient to develop increased risk of stroke, right? So you need to initiate treatment, not just the antiplatelets, but focus on the entire spectrum. So I hope all of you are now confident enough to manage cases of TIA on your own. Thank you.